How do we incorporate weight-bearing restrictions into some of these transfers? That might be a question some of you are asking. What if the patient is non-weight-bearing on a leg, and we still want to train them, say, to perform a squat pivot transfer? Right? Do you have any thoughts on that one, Ms. Brennan? Check this out a little.
I do.
Okay.
So someone, if they have a weight-bearing restriction, let's say on the right leg, when you're trying to teach someone to transfer, it's easier to teach them to their unaffected side, okay? And then when they've mastered that, then we teach them to transfer to their affected side.
Absolutely, yeah. Start out with what's going to be more comfortable for the patient. How are they going to have more control? That goes back to the question you asked, Ashley, about which side do they transfer to. If they're a BKA, who's fresh, or say if they have a knee immobilizer on, and that knee has to stay sticking straight out that whole time, that's probably going to get in your way a little bit, right? So we would initially transfer toward the other side. For the purposes of this, let's have you be healthy leg on that side, okay? And we are going to teach her to transfer toward the right side. The right side is her strong side, so this would be the first transfer we initiate with the patient, right? Squat pivot. And say that previous to this, you were perfectly functionally independent in the community, right? You had no assistive devices needed for gait. You're functionally able. You just happened to fall down some stairs and fracture the distal femur, resulting in an ORIF and a knee immobilizer for 4 weeks.
Okay, ouch, okay. Alright.
Yeah, but that tells me too, like, doing a chart review, guys, and knowing what functional level the patient is at before the state that they're in is going to tell you a great deal about what they're going to be able to perform, right? So I might start with the squat pivot, but then have that underlying, you know, I know they were walking, they were up on their feet before this. I want to get their upright tolerance where it should be as well. So performing a stand pivot. Can they perform a stand step transfer if they're non-weight bearing on one leg? What do you guys think? Kind of a trick question. I'm non-weight bearing on one leg. Can I still perform a stand step?
Yeah.
I can, right? It's a 3-point gait pattern. So I can still stand step. Or I can stand and pivot. Right? Those are my options. Even with non-weight bearing on one leg. Okay. For squat pivots, you don't need the assistive device, right? But if they're gonna start performing stand pivots and stand steps with a non-weight bearing extremity, we're gonna want some type of assistive device technically. Or not technically, usually, right? Some of your higher level patients are gonna be perfectly fine. You know, your 20 to 30-year-old patients hop right up and they're on one leg and they're fine and they're spinning around. Awesome. Don't reinforce those behaviors though, because that is risky for the patient. They already have something fractured, right? Why have them engage in more risk-taking behaviors before they're fully healed? So reinforce safety when at all able. Let's say, right, back to the left leg, non-weight bearing. We're gonna have you stand with me. This is a problem, right? As a practitioner, I'm now further away from the patient. So where should I stand?
Where should you stand, guys? Which side?
Affected side.
The affected side.
See, I'm standing on the affected side. Because when a patient's standing, right, this other leg's doing the work, right? They're gonna tend to lose their balance toward the affected side in standing. So if she is standing, let's go ahead and stand together on 3. 1, 2, 3, up. Awesome, right?
Okay.
If she loses her balance, it's going to be towards me. And all I have to do with that is push her hips back away towards me onto her strong leg.
Okay.
Right? How you doing?
Good.
Dizziness? All right.
Nope.
So let's have you pivot a little bit. Can you turn towards me? Stay on your right leg. Good. All right. All right. Let's bring this back. Good.
You come around.
Hands on her, right? And never lost contact with the patient. Ready to sit?
Yes. It's a little cumbersome.
It is.
Yeah.
It honestly is. It's difficult working around assistive devices with transfers.
It's a tight turn.
Yes.
When sitting down, would you want to be on the affected side?
there wasn't room. Right. Optimally, you would be on the affected side.
Like already?
No, yeah. Optimally, you would be on the affected side.
You could in a wheelchair,
You could.
if you had enough strength and your patient was safe enough to stand there.
That's the key, right? If the patient has enough strength and they're safe enough to maintain standing while I get rid of the wheelchair, then I'm diverting my attention away from the patient. So really, once I get her to standing, I want to focus on her and the surface that we are transferring to. There is an advantage of positioning yourself toward where you're transferring, right? Some patients will stand and try to throw themselves toward where they are transferring, right? Me being in that position now, I can guard if you decide to suddenly impulsively throw yourself toward that, right? I'm here to kind of guard that technique, right? That's just about it, guys.